I will hand over to my colleague Dag, who is the Professor of Old Age Psychiatry at our Institute of Psychiatry, Psychology and Neuroscience, our close collaborator, close partner in our research, and also industry partnerships. So he leads the Center for Healthy Brain Aging and also a HealthTech research center funded by NIHR, National Institutes of Health Research. It's a government NHS academic clinical entity for industry partnerships, especially our global network, which Dag will speak about. Anyway, hand over to Dag.
Thank you. Thank you, Richard. Good afternoon, everyone. Nice to see you.
And I'll continue sharing for those online.
Thanks for inviting me. And colleagues, very nice to have you here, Angus. And we have a long history of collaboration, and we hope that we can build on that and create new specific projects that can benefit the aging population, both in the UK and in China. So I'm a psychiatrist, as Richard said, and so my focus is on the brain. And I didn't have a chat about that earlier. It's good for people to live longer, but it's also good for people to live longer with a good, well-functioning brain. Otherwise, it's not so good. I think we all can agree on that, right? So that's why healthy brain aging is a big topic of what we do. So we deal with diseases. We also deal more and more with prevention. And one of the things I wanted to mention is that we just, in our chat, you also discussed this new 10-year plan, UK government 10-year plan for NHS. And the 3 pillars there are prevention, moving activities from the hospitals to primary care, and digital, moving towards digital technologies. So, and as you will see, many of the things I discuss will fit with those 3 elements, which is good. That was, I think that showed that with Richard and us, we have been identifying what are the real important areas and opportunities in the future. So, as I said, focus is on aging brain, and the main challenge with the aging brain is, of course, the development of dementia. That's just the end stage of a variety of disease processes which can lead to dementia, which is just cognitive impairment and loss of independence because of that. We have Alzheimer's disease as a main cause, but we have a lot of other diseases of neurodegenerative and cerebrovascular. And as I will show you also, there is a close link between the brain and the rest of the body. So the brain is not living in isolation, it's connected to the heart, to the vasculature, and the systemic environment. So just a few numbers, 50 million worldwide today, and these numbers are increasing. The costs of dementia are just mind-blowing. And this is obviously not a Western world or UK problem, this is a global problem. The main rise in people with dementia is coming in China and India, in Asia and also Africa, because of aging population. So we have huge challenges ahead of us, but also huge opportunities. And just that these are the 3, just to remind you again, the 3 key elements of the 10-year plan: community care, hospitals, digital transformation, and prevention. So we see to the extent to which we can meet that. Thank you. So one of the things that we have that I want to talk about is we have set up a remote brain health clinic. SLAM is the South London and Maudsley Mental Health Trust, Europe's largest mental health trust. All of South London mental health is in this hospital. And within that, we have services for older people. We have a brain health clinic, which is a new development, and it's a remote clinic. So I see my patients who come in for memory problems on the screen. It keeps meeting, and we have digital solutions for a variety of tests and activities that we do. So we have a fast, precise diagnosis, evidence-based risk reduction. We also work on a lot on interventions. So with the next slide, you will see, Richard, how it works. So we see patients, we get referred, we go through the history, medical history, we do clinical evaluation, we do biomarkers, biofluids, and imaging, and we try to move imaging towards a much more technology. I'll talk more about that. Here you can see a picture of an automatized analysis of an MRI scan. So usually today, MRI scans are taken by a neuroradiologist. They're really good, but there are few of them. There's a long waiting list to come there. It's really expensive. Using machine learning and AI technology, these scans can be analyzed very quickly, very accurate, and much more detailed than with a human eye. And then we have some, depending on where the patient ends, we have a number of activities, post-diagnosis for intervention and improving and preventing further decline. I'm going to quickly, so we just do all of this. So we have won a number of awards, but this is very popular. We have had a nice paper, a nice editorial by Ivan Kochev, showing that this is the future of UK memory clinics. Let's move on, Richard. Okay, there we go. So we are very proud of this. We were just nominated for Royal College of Psychiatrists, one of the nominations for the best research active clinic in UK. So I just want to say that we are good at diagnosing, using new technology for diagnosing, but that's only part of it, right? You have a diagnosis. What can we do in order to help the patient? And we're setting up some lifestyle therapies, as Richard mentioned. You know, we have drugs for Alzheimer's disease now coming. I'm not going to discuss that. That's fantastic development and a huge progress. Not yet in practice in the UK. I don't think they are used yet in China either. They are used in the US. They're used now starting in Europe. They're used in UK, but they're not reimbursed. So it's only for private patients, and it's very expensive. But more than £100,000 each year. But what else can we do? We can have cognitive well-being group. We can have lifestyle interventions, and we can have mindfulness meditation. This is a Chinese PhD student that Richard mentioned, Bill Hongjoy, that has a very exciting project where she sees patients who have been diagnosed in an online group meditation style. So, which is really helpful. Patients love it. It's not curing the disease, but it's helping them cope with it, reducing anxiety, learning to breathe, reduce stress, which is good also for the brain and for the quality of life. So we have a number of these lifestyle interventions that we can offer to all patients. Among the many PhD students that we have, I wanted to mention particularly Greg Cotspower, who is he is a successful entrepreneur from Silicon Valley in the US, where he has developed a system for human setup. So he has developed this system for an avatar type technology, you can see here, which can provide post-diagnostic support for a patient diagnosed with Alzheimer's disease. So we see patients, we do the stuff, we see the results, we talk to the patient and tell them you have Alzheimer's disease, talk a little bit about the disease, and obviously that is a kind of a stressful event. You ask them, do you have any questions? Usually they say, no, right, because it's just too much. But we all know that a few hours later or the next day they have hundreds of questions. But then we are seeing the next patient, so we are not available. But a digital avatar, a digital human, a digital support system can be accessible 24/7. So this digital avatar then knows the history of the patient, knows what about the Alzheimer's disease, about treatment opportunities, knows the local opportunities for interventions. So the patient can then log in and talk to Dr. Smith, who talks back to him about the opportunities. Really an amazing, fantastic, and really cost-efficient, cost-saving system if it works. And that's what we will see. Does it work? Do the patient like it? Can it be implemented in NHS? And Richard mentioned our HealthTech research sector. Yesterday we had a big event with NHR about the HealthTech research center at NHR, which is the research arm of NHS. 1% of the NHS budget goes for research. That might sound much, but it is, of course, a lot of money because NHS budget is big. And one of the main funding streams are these HealthTech research centers. We have 14 different centers. Our center is on brain health. So we won this award last year. So we have now started setting up. We're working closely with the industry. The mission of the center is to support industry to get their technologies into NHS to help patients prevent or treat dementia or cognitive impairment in older brains. So it's really, really good. And we have more than 40 companies working with us. And we can support them in different ways. We can have entrepreneurship. We can give them a little bit of seed funding. We can help them with grant applications so that we can have funding to test out, further develop technologies. And we have many of these technologies are digital technologies, cognitive testing, sensors development, etc., etc. So this is really a great opportunity and a good example of how we in the academic and clinical medicine NHS work together with industry. So those of you wanting to maybe invest or talk with investors, this is a place where people can meet up with really interesting new technologies. Many startups in this group. Richard is the key coordinator for the food industry. The industry people, I all know Richard for some reason from all over the world. They contact him and then we together work with them. I mentioned imaging. In order to diagnose what's going on in the brain, imaging is a fantastic source and there are amazing developments in imaging technology. However, they are expensive. As I said, they are in the hospitals. They need extra radiologists. We have Ash Rahman, a brilliant postdoc, psychiatrist and imaging researcher. He works with a company called Hyperfine, who have developed this portable ultra-low field MRI. So this is an MRI scanner, but it's small. Here you put in the head. You can put this scanner. You can put it in the car and drive it around. So we can actually move the scanner from the hospital to the community. So that ticks one of the boxes from the 10-year plan. Imaging does not need to be done in hospitals, can be done in the community with the new technology. Much cheaper. Obviously not exactly the same quality as more expensive ones, but still good enough to do a very a good job for our needs. So we are now testing these new small scanners, how they perform compared to the standard large scans. In addition, we use automatized analyzed of the scans, as you can see here, so we can reduce the time and cost for imaging in 2 ways: cheaper scanners, more accessible scanners, and automatized analysis of the scan. So that is really an opportunity to improve the health cost pathway. I mentioned that the new asthma drugs are not reimbursed, not approved by NICE, and the reason is cost. And one key cost in the drug, it's not only the drugs, it's also the monitoring, because these drugs have a risk and they need frequent MRI monitoring. So a big part of the cost for drug treatment for Alzheimer's disease is a scanning. This is a way of potentially reducing the cost and hopefully making the drugs more accessible to us. How's time going?
I carry on.
Thank you. So I want to talk about a few of our main European collaboration or projects. So we need 2 big IHI projects. What is IHI? Innovate Health Initiative, one of the biggest EU Horizon funding streams, and it's public-private. So the industry pays half of the cost, the public EU tax money pays half of it. It's a really brilliant way of working together with various industry companies in a pre-competitive space with academics and clinicians. So this is prediction. This is now halfway through. Started in November 2023. which is a project of prediction of Alzheimer's disease using AI-driven screening platform. It is it's actually led by Kings, but my other hat is Norwegian, and this is a Norwegian sponsor because it happened during the post-Brexit when the UK could not leave the EU project. So it's actually practices itself from here. And you can see GE Healthcare is a main limited partner, but also Siemens, Novo Nordisk, and other big pharma and many small companies are involved. And yes, next one, please. The key of Predictor is linked to what I talked about earlier. It is about improving the dementia assessment platform. So we are moving the diagnostic process to people's homes. So we are testing out a range of biomarkers that can be completed in people's home. For example, you can do a blood test, with a fingerprint test, and analyze for Alzheimer's changes. And the digital tests that you can do at home with your computer or your cell phone. We can collect saliva for epigenetic analysis and collect stool for microbiome analysis. We can do eye tracking. All these kind of things can be done in people's homes. And we will check if these, to what extent are these home-based biomarkers linked to having Alzheimer's disease in the end. So the first step is home-based testing, then we set up a system that the GPs can do. And then in the end, they have a state-of-the-art Alzheimer's type diagnostic test. So the question of this project is how accurate can the home-based and GP-based biomarkers be in terms of diagnosing Alzheimer's disease? So again, it's moving back to the three NHS, 10-year NHS plan. This is about moving activities from hospitals to primary care, or even to people's homes, right, to communities. So if this is successful, it means we can move a lot of activities towards communities. Huge cost saving, capacity increasing. And obviously, this is a lot of, it's a huge amount of data. So we need AI and data science to handle this data. Excellent. So this is another project which hasn't started yet. So this is the secret. It is not yet a project. It will be a project in January. We are now in the very tedious but important grant agreement stage. We are having all the partners to sign. We have more than 20 partners. This one is led by Siemens and with Amsterdam and Kings as a key clinical leads. And the vision here is again to make technologies that exist for AD accessible for everyone. Not only those who live just 100 meters from Queen Square or from King's College Hospital, but for everyone. How can we develop technologies that can help the diagnostic and treatment process where people live in the community? It's really an opportunity to make the technologies available for everyone. Really exciting project. Hopefully, if you come back next year, we have started, and then we can talk more about that. We have a wonderful academic GP, Kate Mariam Molokia, who is involved in many of these projects. And Mariam and us, we are together. We are working a lot on how can we engage and can we provide tools for the GPs so that they can make sensible decisions. And one important decision they can make is which person coming to me with a memory concern do I not need to refer to those? And there are now tools, technology available, for example, a blood test. It's not yet implemented, not fully tested, and particularly not tested in the primary care setting, so that needs to be done, and that's what we are doing. Can we use the new technologies in primary care and then identify people who need further assessment, or can be just treated by the GP, not needing more sophisticated examinations? That is also a way of improving capacity by reducing the burden. We already have long waiting lists. We expect more longer waiting lists, and more people age, NHS is reducing, and the new drugs, new opportunities coming. People want this. They go to the GP. The GP, without any tool, can only then refer to the memory services, and they are already clogged. But that doesn't work. So we need to empower the primary care healthcare system to do more sensitive things. So that's what we are doing. For that, we need technology and investment. And the last section, if I have 2 more minutes.
Yeah.
Is about, as I said, the brain is not living by itself. It is part of the body. A lot of interact between the brain, the gut, pancreas, the sugar metabolism, the heart, the blood vessels, the lungs. So there are a lot of interactions. So the brain can reduce function if there are diseases here, but can also reduce its function if there are problems in the heart or in the vasculature. So that is an important area that we need to focus on. And one of my brilliant postdocs is Mikael Barber. He is lead author here together with Peter, where we just demonstrated that the muscles, which are a key function, we talked about the professor of sports medicine, right? So the muscles are important for many reasons, but also for the brain. We know that there's strong links between the muscles and the brain. And when we use the muscles, that releases anti-inflammatory molecules and a lot of other positive systemic effects on the brain. And here we studied in the UK Biobank association between muscle function and brain atrophy. And this figure means that people who have poor muscle function have reduced brain volumes, where we adjust for all possible factors. So there is a clear link between the muscle and the brain health. So that means physical activity is good for the body, but it's also good for the brain. And frailty, which is a condition where older people become more vulnerable, more prey, because of a number of diseases, drugs, and aging altogether, and inflammation, which is an important part, an important driver of functional impairment and costs. And there's a clear link between frailty and dementia. If patients are frail, they have a higher risk of dementia, and if they have dementia, they have a higher risk of frailty. So we have a number of negative circles. And again, Miguel is leading this European expert group on frailty and dementia, and just published it was in this year, 2025, I think. So this is a guideline, summary of the current state of the art with this regard. And I think that is the last one. We work a lot with nutrition as well. Physical exercise, we have also nutrition. And what we eat is important for the body and the brain through various ways. And one of the things we do is to test supplements. You know, if you Google what should I eat, it's good for the brain, you can have 100, 100, 200 different suggestions. But what we want to do is to test these. Are they really good? Are they really helpful for the brain? And that's what we wanted to do. So this was one study where we used anthocyanins. Anthocyanins are the things that are in fruits and berries in small colors, like blueberries and other vegetables and fruits with colors. And they have a number of positive effects. So we tested whether anthocyanins could have effect on people of high risk for dementia. We did not see any effect on cognitive function. These are then scores on a cognitive test. But then we said, okay, what about people with or without low-grade inflammation? Do they different by response? And the finding here is that in those people with inflammation, this group, there was a positive effect. This is the active group, and this is a placebo. So it means that this supplement worked in people who had inflammation, but was not effective in people without inflammation. This is only one small example, but the main point here is about precision of personalized medicine. Not every intervention works for everyone. So we need to find out who are the people who can respond to the various interventions. We discussed that for physical exercise, maybe someone needs this exercise or that exercise. And here is about maybe someone benefit from that diet, that certain versus other diet, benefit from another diet. But how can you find that out? We can have biomarkers. These are blood-based biomarkers on inflammation, but we have microbiome and a lot of other elements where we can look at that. So that's it then. So just to repeat some of the main points I wanted to convey. So future needs are huge in terms of cognitive, mental assessment, and dementia. But there are also new technologies that present new opportunities, diagnosis and treatment. And we have our, here in Dag Aarsland, we have our health clinic, first fully remote memory clinic in the UK. And we are offering a range of research-based interventions, both in clinic, but also testing and out. And we are leading many national and European research projects in this scope. So we are really keen to develop our links with both academic and industry companies. We have a lot of international contacts, not only in Europe, but also with South America and also with China. But we have this potential for growth, right, Richard?
That's right.
So that's.
And can I just add, because we're partners in industry engagement, it's partners in happiness, maybe. But it's also thanks to the British Embassy in Beijing that we have our collaborations with a Chinese nutraceutical company. You know about that. So we're looking for partners anywhere in the world, especially China, with TCM. So how we can understand TCM, which includes exercise. TCM is not only, eating something, but the exercise, mindset, and so on, breathing patterns. Needles, yes, acupuncture for brain health. And it's across the life course. So later on, we'll have a talk about what happens in young people, babies, and so on. We have to start at a young age and consider across the life course, culture and environment, so that we can end our days in a happier condition.
Yes.
Anyway, thank you so much, Doug. Any questions for Doug? Because I think Doug needs to leave earlier. So if there are any questions, he'll take them now. Doug, would you take some questions? And for those of you who are online, please add your questions to the chat. If you've got questions, we can also ask them. Questions? Any questions? If you want to ask in Chinese, Doug is fluent. He can understand. Yes, no. I'm sure Jean can translate. Sorry, not sure why that was. There's a question that can be translated. Can you translate, Jean? Is there a question? Does anyone have a question?
Yeah, there are a number of technology. One is digital testing. So we have we don't have one specific system, but we have contact with the provider. So yesterday, for example, we had dinner with one company who has developed a specific cognitive tests. So we have a variety. So our aim is to test devices and then implement them. So currently we are using a very standard things, but we are always on the lookout for more efficient and novel ways of doing it. So we can do both active test, people do test on their phone or on their computer, or passive sensor based. So, and passive in the sense of using mobile phone, just talking into the mobile phone, and the way they handle their mobile phone. So lots of technologies. We haven't implemented one at least, but we are exploring a range of technologies.
Yeah.
Data collected, or is, for example, is the blood?
Yeah, right. That's so we have the cognitive testing,
Yeah.
or behavioral testing, but then we have the biofluid biomarkers. And the new development are that we now have blood-based markers. They are not yet approved by NHS or NICE, but they're really good data supporting their use. So we are, and that's also something that we are implementing. Blood-based biomarkers for Alzheimer's disease, for example.
So the HealthTech Research Center is all the way from blood biomarkers, so diagnostics, to digital biomarkers.
Yes.
So technologies and imaging. So digital technologies, imaging to get the data, to build the data sets together for better prediction. And I know that we will, you had a program called Radar AD that's using home-based technologies tracking for cognitive decline. So digital technologies all the way through to blood and biomarkers and CSF.
要么移动数据，要么内容以外，也有血液，但血液内容还没有被审批。
So wearable technologies are important, especially for those with cognitive decline, and also for the young.
同时，一般来说，心肺功能也差，社交也差。到底是肌肉少直接导致这个不行呢，还是心肺功能差的这个因为心脏血管的供血，或者是社交少导致这不行？到底哪个？条件关系还是间接关系
So for the muscle, lack of a muscle can result to the brain,
？Yes.
slow brain. So what is the direct hit? Yes. Through lack of
There are, yes, use of the muscles has a lot of positives for the body, but also for the brain. So we have in addition to, let's say, general cardiovascular effects, which are positive, we also have direct muscle brain impact by means of circulating molecules. When we use the muscles a lot and we exercise, then that frees out molecules of the muscles that have a positive effect on the brain. And vice versa, if we are not using the muscle, the muscle produces pro-inflammatory.
So yeah, inflammation.
Inflammation is one mechanism.
And also metabolic.
Genesis and metabolic.
So Professor Gold's question is, what is the direct impact or indirect?
Yes, both. There are many. There's not only one. Many direct and many indirect.
That's what we're doing the research. And when we find out what are those mechanisms, then we can target those mechanisms, whether it's diet, lifestyle, PCM.
这样是不是跟那个和我非常合适，是不是肌肉少了一个我动手去？
You can show me the second proposal, right?
Yes, yes. At least this is an area of research, but there are lots of there's evidence supporting that, and there are many mechanisms we know happening when muscles are used that have a potential positive effect on the brain. So direct cause. So if you need another argument for exercise, you have one. Addition to anything else.
Any other questions? Sorry, there was one question online. Sorry, Doug, there was one question online. It says, what are the ways to quantify quality of life scores? Are there examples of cognitive tests? Do you see this one?
Well, there are both quality of life scores that we can implement for the patient, and there are cognitive scores. So there are two different, let's say, behavioral aspects that we can rate. Quality of life is challenging, but it's doable. There are approved scores for that. I'm looking at you, but I don't know.
No, that's okay. Someone online said that.
And then there are a number of cognitive measures that can be done. We talked a little bit about that, but we have a number of digital measures with that. The neuropsychological testing is moving rapidly into digitalization, which is very, very cost efficient. Instead of having a neuropsychologist sitting down 2 hours or 3 hours meditation, they can do it themselves, even home-based, as we talked about.
Well, this is a very important question by Rupali, because it says, how can we apply these to global population?
Yes.
Because quality of life in the UK and how that's scored may be very different from China.
Yes.
And whether you're urban area or rural area, your quality of life, and whether you're Norway, so Dag is Norwegian, and quality of life is much higher there, and in South London it's not so high normally. So
yes, but I mean, there are
I know.
all these scales have been translated and adapted to different regions. But I think the key thing here is that these cognitive tests are extremely scalable. Patients can download an app, for example, and do the test, and the data are flowing directly and being analyzed on the spot. So it's a really amazing opportunity to scale up cognitive testing.
that's great. Thank you so much, Dag.